Let's go ahead and start to apply some of the things that we've learned. Let's take a look at urine pathogens and urine cultures and urinary tract infections. Here we go with Unit 12. Now, anytime you collect samples for microbiological testing, there are some general rules that we want to follow for collecting that culture material. The culture material must be collected from the actual site of infection. We want to make sure that the culture material is collected from the site of infection and not contaminated by any surrounding material. The samples have to be collected at optimal times. So we have to determine or consider the pathophysiology of the disease, etc. So something like urine cultures have to be collected in the first morning sample. The quantity of the sample collected must be sufficient. So for example, for urine cultures, 10 milliliters is okay, minimum for urine cultures, but you have to think about things like bronchial alveolar lavages. When the doctor orders everything and they only give you like 2 mils, that's not enough for a respiratory culture, an acid-fast culture, and a fungus culture, so we want to make sure we always get the proper amount of sample collected for the types of cultures the doctor is ordering. We want to use the correct collection devices and containers when collecting the sample. For example, if we're collecting a urine sample, we want to put that in a sterile container. We want to obtain cultures prior to the administration of antibiotics. That's really important that we collect our sample material prior to any antibiotics being given to the patient. And we want to obtain the proper physician request indicating the type of culture ordered. So each sample should come with a requisition, and we want to make sure that the requisition matches the sample that we actually got. And then all collection containers and aliquots must be labeled properly. We always want to make sure that we label the container and not just the lid, because the lid can actually get separated from the sample. So those are some general rules to follow when collecting samples for culture. So here's a proper way to label a microbiology culture container. First of all, on the container itself, not the lid, we want to put the patient's full name. Middle initial, of course, is optional. The identification number or the hospital ID number or accession number needs to be on that sample. We want the name of the physician. First and last name of the doctor is actually pretty helpful because sometimes you can have doctors in the same town that are related and have the same last name. We want to make sure that the collection date and time of the sample is written on the specimen, and then we have to know the source of the specimen. Is this a urine specimen? If so, is it a urine that's a clean catch, or is it a urine that's a catheterized sample? Those are all things that we need to know prior to culturing our sample. So let's talk a little bit more specifically about urine and urine cultures. It is true that a fresh urine is considered a sterile body fluid, and any bacteria that's in the sample is something that's going to represent a true infection or it's a contaminant from the skin. Usually the contaminants that are found in urine is normal skin flora such as coag-negative Staphylococcus or Lactobacillus. Urinary tract infections, or UTIs, are very common. They account for 2.7 million hospital emergency room visits since 1995. And these urinary tract infections can be from the upper or lower urinary tract. So the upper part of the urinary tract would be the kidneys and the ureters, while the lower part of the urinary tract would include the bladder, the urethra, and the prostate in males. Some patients have only one episode of a urinary tract infection and they never have another one again in their lives, and others have chronic urinary tract infections. Often the cause of a urinary tract infection is the gram-negative enterics. E. coli is the #1 cause of a urinary tract infection, and Proteus mirabilis is the #2 cause of urinary tract infections, and those are both enterics. You might want to be familiar with that term bacteriuria, and that basically means bacteria in the urine. So like I said in the previous slides, urine should be a sterile body fluid. So if a person gets a urinary tract infection, how does that happen? And there's 3 ways that a person can get a urinary tract infection. The most common way is called the ascending route, where you have flora that comes from the anus and it goes up to the urethra, up to the bladder, and up to the ureters and into the kidneys. That's usually because of the way a female wipes themselves after voiding. We also have the hematogenous route where bacteria originates in the blood and it's not filtered out by the kidneys. In cases like this, our patients have bacteremia where they have intermittent showering of bacteria in the blood, and that bacteria is not filtered out by the kidneys, so they end up getting a urinary tract infection through the hematogenous route. And then finally, the third way a person gets a urinary tract infection is through the lymphatic flow. If that lymphatic flow is contaminated with bacteria, that can go directly through the kidney. Okay? It's very interesting. People that have bacteremia and urinary tract infections caused by certain bacteria, that bacteria can also be noted sometimes in the blood if they have septicemia. Same bacteria that's in the urine. Now, I don't know if you've ever seen this painting. This is called American Gothic by Grant Wood, and you may be wondering, why did those people look so unhappy? Well, what you may not know, this painting was done in the pre-antibiotic era, and the female in this picture had a urinary tract infection, and the guy, he is not looking very happy either, and that's because if mama ain't happy, nobody happy. I'm kidding, of course. This has nothing to do with urinary tract infections. But it is interesting that males are more prone to UTIs due to proximity. Females are more prone to urinary tract infections due to the proximity of the anal opening to the urethra. Now, after the age of 70, urinary tract infections are just as common in males as in females, and that's because once you've reached the age of 70, you cannot empty the bladder all the way or completely. So here's some terms I want you to be familiar with. The first term is chronic UTI, and that's when patients have been treated with a wide variety of antibiotics, but those organisms are resistant to antibiotics, and so they continue to get urinary tract infections. We also have calculi-related urinary tract infection, where patients have a history of kidney stones or a high urinary pH that's very alkaline of about 8 to 9. People that have urinary kidney stones are usually people that have stones made of crystals that are calcium oxalate or calcium carbonate. Pyuria is the presence of white cells in the urine. Bacteriuria is bacteria in the urine, and bacteremia is bacteria in the blood. Now, it's really interesting. If you have a urinary tract infection, you can correlate what's going on with the urinary tract infection to the chemical dipstick when you've done a urinalysis test. For example, if you have a urinary tract infection, the urinalysis exam will show positive white cells or positive leukocyte esterase, positive nitrite. Blood could be positive or negative, and then the microscopic findings if you have a urinary tract infection would be white cells in the urine, bacteria in the urine, and even red cells in the urine. So it's interesting that you can correlate what's going on with the urinary tract infections to what happens on the urinalysis chemical exam. Now, urinary tract infections can affect any part of the renal system. Cystitis is when you have a bacterial infection of the urinary bladder, and pyelonephritis is when you have a bacterial infection of the kidney or kidneys. So cystitis and pyelonephritis refers to where the infection is isolated. Okay? If you have a urinary tract infection, what you may see is a yellow-colored urine that is hazy or turbid. The chemical tests reveal increased pH, leukocyte esterase, which correlates with white cells, blood and/or nitrites. Microscopic examination may reveal bacteria, white cells, red cells, renal cells, or even cellular casts. So pyuria is when you see white cells in the urine. In women, if you have greater than 8 to 10 leukocytes seen in an uncentrifuged urine per field, it means that our patient has pyuria. In men, on the other hand, if you have greater than 10 leukocytes per field seen in an uncentrifuged urine, that is pyuria in men. Here's a list of the signs and symptoms of a urinary tract infection. You can have a fever, chills, heaviness in the abdomen or flank pain, frequent, urgent, and painful urination, turbid or foamy urine, urine with a strong ammonia odor, and then you can even have symptoms like nausea. Now, the symptoms of a urinary tract infection are very similar to a person that has vaginitis or prostatitis in males. There's also such a thing as an uncomplicated urinary tract infection versus a complicated urinary tract infection. An uncomplicated urinary tract infection is usually one that is seen in healthy and active females that are young and sexually active. These are people that have urinary tract infections that are usually associated with E. coli. A complicated urinary tract infection is one where the patient has a neurological or renal structure abnormality, and this can cause a complicated urinary tract infection. Sometimes our patient has fistulas or other anatomical issues. Indwelling catheters can cause complicated infections because our patient could have many organisms present in the urine. The organism is not easily controlled with antibiotic therapy. That can also cause a more complicated urinary tract infection. Some contributing factors to people getting a urinary tract infection would be if they have a high urine pH in the bladder. If you have high amounts of ammonia or an alkaline pH, this could cause bacterial infections and bacterial multiplication. If you have sluggish blood flow through the kidneys or poor filtration of waste through the kidney, you're more going to be prone to urinary tract infections. If you also are prone to reduced leukocyte chemotaxis, where the white cells don't migrate to the site of infection, this can lead to a urinary tract infection as well. There are several steps involved in the diagnosis of a urinary tract infection, and there are several steps that we have to go through to diagnose a UTI. First, we want to collect the sample, and we want to make sure that the sample is properly collected. For example, if we're doing a clean catch midstream, we want to make sure that the genitalia is cleaned and that the first few milliliters of urine are voided in the toilet, and then we collect the midstream. We want to make sure that that urine is put into a sterile container. We want a complete physical, chemical, and microscopic examination of the urine. This can be done in the urinalysis department. We interpret the initial findings, culture the urine specimen if indicated. So if indicated by leukocyte esterase or white cells seen in the urine or bacteria seen in the urine, this is all going to indicate that a urine culture needs to be collected. Then once the urine culture is collected, we grow out the organism, we identify the organism that is causing the infection, and then finally we do sensitivity tests if necessary. So what we do there at the very end is we do a Kirby-Bauer or a microscan or an e-test, something to give the doctor a range of antibiotics that can be used to treat their patient. There are a number of urine specimens that can be collected for a urine culture. Okay, so there are many types of specimens that can be collected. One such type is called clean catch. Another type is called clean catch midstream. Another type is a catheterized specimen, and that comes in two different types. One is called an indwelling catheter that stays in the urethra and bladder for a long period of time. And then there's another type of catheter called the straight cath. The straight cath is when they insert the tubing into the urethra and bladder just for a small period of time, and then they remove the catheter. Okay. We also have what's known as suprapubic aspiration and cystoscopy. Anytime a physician collects a catheterized specimen, there is always a risk of introducing an organism to the sample from organisms that are living on the urethra. And this mostly refers to straight catheters. Straight catheters don't stay in for a long period of time. It's used in the emergency room or on kids or people that are paralyzed. For indwelling catheters, the sample must be collected by puncturing the needle itself. So here we insert the tube into the urethra and in the bladder, and then a 28 gauge needle and syringe is put into the tubing, where the tubing has been disinfected and then it's being punctured and the sample is aspirated. Anytime we're dealing with a catheter specimen, a colony count of greater than 1,000 colony forming units per mil is considered significant. So anything less than 1,000 colony forming units per mil is considered insignificant. Probably the most common type of specimen that is collected for urinalysis and urine culture would be the clean catch midstream. This is easily obtained. Usually we get the first morning void. That is optimal. Also, it's easily replaced if it gets spilled. Counts between 10,000 and 100,000 may be significant, but counts of over 100,000 colony-forming units per mil are definitely significant. Counts of less than 10,000 colony-forming units per mil are insignificant. Okay, this is the preferred method of collection for routine cultures, and we have to inform our patient of the proper collection technique. So with a moist towelette, you can clean the external genitalia and the skin around the urethra. The first few milliliters of urine are voided into the toilet and discarded, and then we collect the next several milliliters of urine into a sterile collection container. A minimum of 10 ml should be collected on adults. Then we discard the last few milliliters of urine into the toilet, and the sample is now ready for culture. A suprapubic aspiration is an aspiration of urine from a direct bladder puncture. This is mostly seen ordered on neonates and small children. It's the only type of urine collection technique that is suitable for the culture of anaerobes. Anaerobes in a clean catch midstream sample can be completely normal. This type of collection, the suprapubic aspiration, requires a direct bladder puncture, and it's not the most common specimen collected. A cystoscopy is a surgical procedure that examines the structures of the bladder and the kidney. This is usually used more to study cellular elements and cellular abnormalities of the kidney, more so than urine culture. Following the collection of a urine sample, we want to make sure that that urine goes into a sterile screw cap container. Make sure that that container lid fits on snugly so your urine sample doesn't leak all over the place. We want to make sure that our container is labeled thoroughly, and we want to make sure that that sample is transported immediately to the laboratory. We want to culture it as soon as it gets to the lab, but sometimes delays do happen. If there's a delay, we can actually refrigerate that specimen, and it'll be good to culture for up to 24 hours. Or we can take that sample and put it on boric acid at room temperature. It's a good preservative for up to 48 hours. When a urine sample comes into the laboratory, we want to examine the container label for acceptability and make sure that all the information that we need is on that specimen container. We want to examine the sample for sterility. We don't want to use any urine that is spilled inside of a biohazard bag. That's just not acceptable. We want to double check the accompanying requisition and make sure that it's actually urine that we are testing. Sometimes other samples are put into urine containers and they look just like urine. One such example is spinal fluid, so we do want to make sure we're dealing with urine. Then we want to mix the urine thoroughly by swirling it. You may or may not be required to prepare a gram stain for the unspun urine, but if you do prepare a gram stain, you want to make sure to correlate what you found on the gram stain and make sure you correlate to any samples on the culture and see if those findings are significant. We can set up our culture plates in the pour plate fashion where we're making a lawn. We usually set up 2 blood auger plates with calibrated loops that are 1/100th of a mil and 1/1000th of a mil. And we'll also set up a McConkey or an EMB plate that has lactose fermentation properties in it. Our MAC or EMB plate is set using a 1/1000 calibrated loop as well. If a direct smear is performed on our urine, we can do that by placing a drop of that urine on a sterile slide using a 1/100 loop. We don't want to spread that drop of urine out. Instead, we want to go ahead and draw a circle around it on the bottom of the slide so we can find it again. We're going to allow it to dry. Air drying is best, but you can use a slide warmer. That's fine too. And then we gram stain the specimen. Once that specimen is air dry, we can look at it under 100x oil immersion field and we can report out the number of bacteria and white cells that we see. We always want to correlate what we see with the possibility of an infection. So for example, if there's no bacteria seen and no white cells seen, it's pretty safe to assume our patient does not have an infection. If there is a rare bacteria or gram-negative rod, usually it's a gram-negative rod, per slide, then we have a borderline infection. If you see a rare gram-negative rod per oil immersion field, it's a probable infection. And if you see more than rare gram-negative rods, or whatever the bacteria is, per oil immersion field, it is a definite infection and it correlates with a colony count of greater than 100,000. Now, A direct smear on urines is not often performed, and it's only helpful for 3 reasons. Number 1, we can correlate the number of organisms seen to an actual colony count. Number 2, we can determine if the sample was collected correctly. For example, if there's too many squamous epithelial cells, it may mean that it was not collected using a clean catch method. And then finally, the third reason a smear might be helpful is the gram stain may actually indicate the type of organism causing the infection. So this is how we go about setting up urine cultures. We're going to use a sterilized, calibrated loop. So this is not our normal loop. These loops are actually calibrated to deliver 1/1000th or 1/100th of a mil to the plates. But we're going to take that calibrated loop and we're going to dip it in our mixed or swirled urine sample. We're going to place the calibrated drop on our blood auger or MAC plate, and we are going to make sure that we streak it 3 ways. So we're not streaking for isolation. We're actually making a lawn and using the pour plate method. We're going to incubate our plates aerobically at 35 degrees, and then after 24 hours of incubation, we can count the number of colonies growing and multiply this number by the calibration factor of the loop that we used to plate the organism. Counts of 100,000 for a clean catch can be reported as greater than 10 to the 5th colony forming units per mil. This is your colony count, and all plates should correlate approximately. Okay. Now anything over 100,000 is considered significant, so we don't keep counting above 100,000. We simply say it's greater than 100,000 colony forming units per mil, and then we know it's significant. After we have got our colony count, then we want to identify our possible pathogen and perform susceptibility testing if it's appropriate to do so. Now, in order for the results to be interpreted correctly, the lab must be given the following information in order to correctly interpret those results. We need to know the collection method. For example, was it a clean catch or a catheterized specimen? Suprapubic aspirates may require many dilution plates to be set as well. For example, you might have to set up a 1 to 1,000, a 1 to 100, and a 1 to 10,000 plate, and that's only on suprapubic aspirations. Okay, we want the collection date and time and the lab delivery time noted. We also want to know any antibiotics the patient might be on, especially if they've been put on antibiotics before the urine was collected. And then it's also helpful to know the clinical diagnosis of the patient. If we know our patient history, it makes our result interpretation a little bit easier. So let's go ahead and take a look at what colony counts are considered to be normal for urine cultures, okay? If you have a clean catch midstream and you have a colony count of less than 10,000 colony forming units per mil, that's considered completely normal, and we don't do an organism identification or a sensitivity test. For catheterized urine specimens, a colony count of less than 1,000 colony forming units per mil is completely normal. So if you take a look at those charts there, you can kind of see in a clean catch midstream, anything over 100,000, you have a definite infection. If you have a colony count of 10,000 to 100,000, you may or may not have an infection, but we do want to consider working up the predominant organism. And by working that up, I mean identification and susceptibility. If you have a colony count of less than 10,000 colony forming units per mil, there is no infection and we don't do an ID or susceptibility. Now, in catheterized specimens, any colony counts of greater than 1,000 organisms per mil indicates an infection, and we would do an ID and sensitivity. Now, on clean catch midstream cultures, colony counts of less than 100,000 may still be significant. We don't know for sure if they are, but they may be significant. So if you have a patient that's already on antibiotic therapy at the time of collection, then a colony count of 100,000 could be significant. If you have a catheterized specimen with a colony count of greater than 1,000 colony forming units per mil, that is considered significant. The same thing is true with cystocath specimens. Okay, and this should be a sterile procedure, but if you have a colony count that's very low, it still could be significant. And then if you have counts associated with gram-positive cocci infections, it could be significant because you may have MRSA or VRE or even something like Staphylococcus saprophyticus. Those are significant organisms. So if you have a colony count of greater than 100,000 colony forming units per mil and it's only one species of organism growing, then we definitely have to do an ID and susceptibility test on this organism and report it out to the physician. If you have a clean catch midstream and the culture has 2 organisms growing on it, but your total colony count is greater than 100,000, we want to work up the predominant organism, or the PO. Usually we do an ID and a sensitivity on that predominant organism. If you have 2 or more organisms that total a colony count of greater than 100,000, but each organism has the same amount of growth, you probably need to get some input from the physician, because it could be colonization. And colonization is when you have several bugs that live in an optimal environment but aren't causing any harm to the host. Okay. For susceptibilities, we always want to include antibiotics that are used specifically for urinary tract infections. Some antibiotics that are good for UTIs would be furidantin or nitrofurantoin. On catheterized urine cultures, colony counts of greater than 1,000 do require an ID and MIC. Now, pretty much any organism could cause a urinary tract infection, but there are some that are way more common than others. For example, the #1 cause of urinary tract infections in healthy, middle-aged, sexually active women would be E. coli. The #2 cause would be Proteus mirabilis. Then Klebsiella, Enterobacter, Enterococcus faecalis and Staph aureus, Staphylococcus saprophyticus, Group B strep, Pseudomonas aeruginosa, Acinetobacter, those are our 2 non-fermenters, Streptococcus group A, and finally Candida albicans. These are all organisms that are more likely to cause urinary tract infections. But again, any organism can cause one. Now, there's a bunch of normal skin flora that could actually contaminate your urine culture. Some of the organisms that can be contaminants would be Staphylococcus epidermidis or any coag-negative staph, except for Staphylococcus saprophyticus, which is generally the cause of urinary tract infections in women also. Diphtheroids, which are gram-positive rods. Lactobacillus, which is normal vaginal flora, could be the cause of contamination as well. Streptococcus viridans, and also Bacteroides or other vaginal anaerobes like Mobiluncus. These are all organisms that are usually not the cause of urinary tract infections, but could contaminate your urine culture plates. And that is all for Unit 16. Hope you learned a lot. Bye.